Now, the thromboelastography is an interesting technique, actually, because it's so flexible, and it can be used to measure all sorts of different things. And it can actually be used to give you an indication of aspirin resistance. And in this particular iteration of the thromboelastograph assay, activation of the blood coagulation is done in the presence of heparin, and then with a cocktail of activated factor 13, reptilase, which I'm sure many of you are familiar with. Reptilase is a snake venom which cleaves only fibrinopeptide A and is insensitive to the presence of heparin. And then platelets are activated by arachidonic acid. Activating factor 13 has to be added because you're not getting thrombin activation of factor 13 in the system, and we want to have stabilization of the fibrin. And if you do that in a patient that is responding well to aspirin, you see the effect on platelet function quite clearly. Again, the blue curve showing no aspirin, and the yellow curve showing what happens in a typical patient that is responsive to aspirin. Now, once again, we see a discordance between this assay and some of the other assays that we've already mentioned in the actual prevalence of aspirin resistance, and the explanation for this really is not clear. With the PFA verified now and the urinary assay, we're seeing 20% and upwards in patients with cardiovascular disease in terms of aspirin resistance defined by each of those methods. If you look specifically at arachidonic acid aggregation, then you see significantly lower. And if you look at the TEG, it appears to be 1% or less. So again, it's really adding to the confusion in many ways that these assays are not really measuring the same thing. But again, if we look at the prediction of clinical outcome, then certainly many of these tests do have a relationship with clinical outcome. Whether they're measuring aspirin resistance or whether they are simply a surrogate marker for something, like inflammation, for example, remains to be established. But the PFA 100, PIT aggregation, Verify Now, and the urinary assay of thromboxane B2 have all been shown to correlate with an increased cardiovascular risk. Well, of course, this really represents a major standardization problem, something that we're far from unfamiliar with in the coagulation world. And we're still trying to figure out the PT and APTT, for God's sake. Why should we be too concerned about this? I don't know. But certainly we've got an issue as to what these lab tests mean. And the ISTH subcommittee led by Dr. Alan Michaelson came out with their position last year. And really, first and foremost, we need to establish a clinically meaningful definition of aspirin resistance. We need to do that and link that definition to some kind of aspirin-dependent laboratory methodology. Then we have a very significant issue that really hasn't been properly addressed at all yet, although studies are ongoing, and that's how do we treat aspirin resistance? What is the appropriate management of a patient shown to have aspirin resistance by one or more of these methods? And our problem is that right now we have no data that links improved outcome or demonstrates to us that if we change therapy, if we jump from aspirin to clopidogrel, for example, that we're going to improve outcome and lessen the risk. So right now, the ISTH's position is that it's not really appropriate to test for aspirin resistance at the present time until we have ironed out some of these issues, and it's not necessarily appropriate until the clinical trial data is in to start changing therapy based on the current laboratory tests. Now I want to just close up with a few comments about clopidogrel. I guess there should be a big red X, not a number 8 next to clopidogrel. This is probably a function of me changing from the Mac to the PC, from PC to Mac recently. Anyway, what clopidogrel does is it blocks the P2Y12 receptor, which is one of 3 ADP receptors on the platelets, the principal ADP receptor on the platelet. And so it reduces the ability of exogenous ADP to activate the platelets. And you can test for that clopidogrel effect in a number of ways. Aggregation to ADP is perhaps the gold standard way of doing it. The PFA 100 has certainly been used to do that. One of the issues, however, is that the current ADP cartridge of the PFA 100 system is somewhat insensitive to the effect of Plavix. The company are working on a new ADP cartridge it's in clinical trials now, and I haven't seen any of the data on that, but hopefully that is going to make the PFA 100 much more useful for testing for the Plavix effect. And the Verify Now the test system has a P2Y12 assay available. which correlates extremely well with platelet irrigation. And there's flow cytometry methodology available on that on the VASP phosphorylation. Again, looking at the literature, looking at the different methods that have been used, there is a sense amongst workers in this area that there is a significant proportion of patients out there that are somewhat resistant to clopidogrel. I'm showing you here 4 studies. And if you synthesize them all together, there's somewhere again about the 5 to 25, 30% range are quote-unquote resistant to the antiplatelet effects of clopidogrel. Why should that be? Again, there's a lot of research going on in this area. The jury is absolutely still out in this, coming up with a consensus in this. High platelet counts, the presence of other medications. There's definitely genetic polymorphisms that affect either the metabolism of clopidogrel with the cytochrome P450 system or polymorphisms of the P2Y12 receptor itself, which all contribute to different responses to clopidogrel. So to summarize platelet function testing, we have a lot of different ways to measure platelet function. They don't all work the same way. They don't always correlate with each other. We have multiple methods. The bleeding time is definitely outmoded. I think we're all agreed with that. The PFA 100 is certainly more suitable as a routine clinical test, and it's probably the only one we have right now that is suitable for use in that regard, in my opinion. We have 2 different methods of aggregometry. They both work extremely well, and all I will say is that Lumi aggregometry does have some significant advantage over optical aggregometry, but you can get the same data pretty much out of both systems. There's some new methods coming along which may well have some specific advantages for certain situations, particularly in the cardiac stat lab. But the TEG is definitely worth a look if you're not that familiar with it, and maybe think about bringing that into the clinical lab, because some of its applications, I think, are really very interesting.